Alright, so in 1999, a 14-year-old girl of Turkish origin presented with vertigo and generalized tonic-clonic seizures. Magnetic resonance imaging and MRI analysis showed multiple hyperintense lesions in T2 weighted images, bihemispheric periventricular white matter, frontal cortex, left insular cortex, and left brainstem. A symptomatic treatment with valproate was initiated. In 2002, 3 years after onset of central nervous system (CNS) inflammation, a mild thrombocytopenia, 110 times by 10 to the third cells per microliter, occurred for the first time, but no further diagnostics were carried out. In the next years, she experienced various neurological symptoms, such as hypoesthesia, weakness of her right arm, vertigo, and double vision. These relapses occurred in a frequency of 1 to 6 events per year. MRI analysis showed a slow progression of inflammatory gadolinium enhancing GD-positive lesions, mostly localized in subcortical and periventricular areas, shown in Figure 1. Conventional angiographies in 2004 and 2008 revealed no signs of vessel stenosis, sinus thrombosis, or other signs indicative of primary CNS vasculitis. Under the assumption of a relapsing remitting multiple sclerosis, these clinical symptoms as well as future relapses were treated with intravenous steroids until 2011. After a patient's presentation to the clinic in 2011, an extensive clinical reevaluation was performed due to increasing doubts concerning the initial diagnosis of multiple sclerosis. Analysis of cerebral spinal fluid (CSF) showed lymphocytic pelicytosis, intrathecal cyanosis of immunoglobulin G and immunoglobulin M, impairment of blood-brain barrier integrity, and positive oligoclonal bands. A differential diagnostic, including serological, microbiological, and virological analysis from both her blood and CSF, revealed no signs for a systematic vasculitis, infection, or any underlying specific autoimmune diseases. Another reason relapse presenting with unsystematic vertigo, we ultimately clarified the nature of her inflammatory leukoencephalopathy by performing a brain biopsy. This showed severe perivascular inflammatory infiltrates as well as diffuse cellular infiltration within the parenchyma. The infiltrates were dominated by small mature CD3 positive T cells and high numbers of CD138 positive plasma cells, whereas only low B cell numbers could be observed. A diagnostic of Evans syndrome, ES, is a rare hematological disease commonly defined by the combination of simultaneous or sequential autoimmune hemolytic anemia, AIHA, and immune thrombocytopenia, ITP, sometimes associated with neutropenia in the absence of known underlying etiology. Based on the detection of CD20 positive B cells and CD138 positive plasma cells, both by flow cytometry assessment of her CSF and by immunohistochemical stainings, we initiated treatment with anti-CD20 monoclonal anti-Rux. This treatment regimen could be beneficially used in CNS inflammation and has already been reported to be effective in the cases of ES. Overall, her prognosis is Evans syndrome.